Assalamu alaikum. This presentation is on the updated evidence base in the management of peritonsillar abscess Quinsy. The diagnosis of a peritonsillar abscess is usually made on clinical grounds. It indicates separation in the peritonsillar space between the tonsil capsule and the superior constrictor muscle. On this MRI scan, you could see the tonsils here, the rounded structures with the art stick in it. The superior constrictor muscle is just lateral to this. In between, there is this small peritonsillar space. Anterior to the tonsil is the palatoglossus muscle there, and posterior is the palatopharyngeus muscles. Just lateral to the superior constrictor muscle is the paraglottic space with the black art stick in it, and a little bit more lateral is the medial pterygoid muscle. Inflammation in the peritonsillar space can cause irritation of muscles of mastication. The inflamed area in the peritonsillar space with collection of pus would displace the tonsils medially and also displace the uvula. A peritonsillar abscess is more common in the age group between 20 and less than 40 years and affect males more. The predisposing factors including smoking and poor dental hygiene and immunodeficiency. Data from England over the last 2 decades had showed a substantial increase in the incidence of peritonsillar abscess. This has coincided with the implantation of policies to reduce tonsillectomy operations, and it was noted that few years later the incidence of peritonsillar abscesses has increased along with other neck space infections. The introduction of more strict criteria for the selection of patients for tonsillectomy resulted few years later in a significant increase in the incidence of adult tonsillitis. You'd see the incidence of tonsillitis in the red line in here, and traditionally it used to be one peak only before the age of 15. Children between the 5 and 15 used to have the highest incidence of tonsillitis. But now the changing face of tonsillitis is that you have another peak here in adulthood. These are probably adults who had not had the operation for recurrent tonsillitis as children. You would see that this peak in the adult tonsillitis also coincide with another peak in the incidence of neck space infections, deep neck space infections, and the blue line, which coincide with the same peak in the adult tonsillitis incidence. And this chart would show the admission rates for peritonsillar abscesses over a 20 years period in England. That showed a significant increase from 6,000 in a year to more than 10,000 20 years later. You would see these milestones in here, the introduction of the Scottish Intercollegiate Guidelines Network 34 and 117 later. Both were advising restriction in the number of tonsillectomy according to some more strict criteria. There was also the introduction of the procedures of limited clinical value that was introduced in 2011 and included tonsillectomy, and was followed later with an increase in the peritonsillar abscess admissions. 2 mechanisms were proposed for the pathogenesis of a peritonsillar abscess. The first, which remains the most accepted theory, is that a quinsy is a complication of recurrent acute tonsillitis. Against that is that about 70% of cases of peritonsillitis abscesses don't have a preceding acute inflammation of the tonsils. Also, tonsillitis is most common in an age group that is about 10 years younger than the age group of the peritonsillar abscesses. The second proposed mechanism is that quinsy follows damage or blockage of Weber's gland, minor salivary gland in the upper part of the peritonsillar space. These can be damaged or blocked by poor dental hygiene and smoking and other factors. and this would cause a localized inflammation in these glands, followed by suppuration that spreads into the peritonsillar space. Two different types of microorganisms can cause a peritonsillar abscess with two different subtypes. The type 1 is a pure culture of a single organism, mostly the group A beta hemolytic streptococci. The type 2 have a heavy polymicrobial growth with different strains of bacteria, including Bacteroids, the anaerobes, and Streptococci, the aerobes. Clinically, the type 2 appears to be more severe, probably because of the synergistic action of the microbial interactions. The vast majority of peritonsillar abscesses would be diagnosed clinically. There would be unilateral throat pain and fever, trismus, and unilateral ear pain and headaches. There will also be difficulty in swallowing and painful swallowing, amounting to drooling of saliva. The voice would be muffled like a hot potato voice, and there would be ipsilateral jugular-digastric lymph nodes enlargement and tenderness. An acute tonsillitis would precede the development of quinsy only in 30% of the cases. In advanced and neglected cases, there may be also symptoms and signs of upper airway obstruction and dyspnea. The vast majority of peritonsillar abscesses are unilateral, but in some cases it may be bilateral as well. In this case, you could see separation on the two sides in the peritonsillar spaces. This is usually associated with an infection by glandular fever infectious mononucleosis, and at one point it was thought that the use of steroids in the management of infectious mononucleosis is the link between the infection and the development of bilateral quinsy, but that link was never proven. Three groups of disorders should be differentiated from a peritonsillar abscess. The first group are disorders within the tonsils itself, like a peritonsillar cellulitis rather than suppuration, or an intratonsillar abscess, an abscess inside one of the deep crypts of the tonsils, usually the crypta magna. And here the abscess will be surrounded by tonsillar tissues all around, rather than being between the superior constrictor muscle and the capsule of the tonsil. And the third is infectious mononucleosis affecting the tonsils. The second group include things like dental or gingival abscesses and minor or even major salivary gland disorders that may push into the parapharyngeal space and displace the uvula, and occasionally malignant tumors of the soft palate or the parotid. The third, more sinister group are vascular anomalies. You could see here a displaced and dilated internal carotid artery displacing the tonsil medially and probably also displacing the uvula. The diagnosis of a peritonsillar abscess is usually suspected clinically and can be established with needle aspiration of pus from the peritonsillar space. This would establish the diagnosis and differentiate between a peritonsillar abscess or just a cellulitis. It also provides material for bacteriology, and that can be helpful in recurrent or non-responsive quinsies to have the right antibiotic for the infection, and also the needle aspiration can be curative in more than 80% of the cases. Routine blood tests for inflammation markers like CRP or white blood cell count would be useful. Also, in cases of dehydration due to the odynophagia, there may be a shift in the serum electrolytes that can be checked by a blood test. And if there is suspicion of infectious mononucleosis, blood test would also help to exclude it. Imaging for a peritonsillar abscess is not required routinely. Transoral ultrasound is a non-invasive method and helps in differentiating between cellulitis and an abscess formation with a fairly good sensitivity and specificity. It also can guide the application of a needle for aspiration or a knife for drainage. It's usually performed intraorally through an endocavitary transducer, but sometimes due to trismus or patient discomfort, submandibular scanning would be required. The findings would show a hypoechoic site of the abscess, sometimes surrounded by a hyperechoic rim of tissues in here. The hypoecho area can be heterogeneous, and you could estimate the amount of fluid pus from the scan. The other advantage it would show, if you're using a color flow Doppler, you could identify the big blood vessels surrounding the abscess, like the vessels in the parapharyngeal space, the internal carotid artery. If there is any suspicion of spread of the quinsy beyond the peritonsillar space, or in cases of recurrent quinsies not responding to management, a computed tomography scan can be useful. It would confirm the diagnosis of the abscess. In almost 100% of the cases, it's very sensitive but less specific. It would show a low density area with an area of rim enhancement around it, and will also identify the big vessels around the quinsy, and would detect any spread of the separation into the parapharyngeal space or the retropharyngeus space or beyond into the mediastinum. MRI scans are less often used because they are more expensive and less available, and also more time consuming, but they allow a better soft tissue resolution. You could see clearly the tonsils and the peritonsillar space separation around it, and there is no radiation exposure, and this is therefore the imaging modality of choice in children. And if MR angiography is used, it can rule out or in suspected vascular anomalies. The area of round or crescentic homogeneous high density would be shown on the T2 weighted. On the T1 weighted post contrast with fat suppression, it would be hypoechoic, and the accuracy is extremely high, both in sensitivity and specificity, with an accuracy of about 96%. There are four main lines. First is the needle aspiration of pus. Second is the incision and drainage of the abscess. Third is abscess tonsillectomy, either unilateral or bilateral tonsillectomy. And fourth is antibiotics. Often the use of needle aspiration or incision drainage is followed after some time, several weeks or so, by elective tonsillectomy. A UK national audit in 2002 showed that most of the UK consultants, like more than 60% of them, would start with the use of needle aspiration as the primary method of abscess drainage, compared with only 25% of the consultants who would prefer to start with incision and drainage straight away. If the needle aspiration fails, then half of the consultants would then perform the incision and drainage. The advantages of the needle aspiration are obvious. It's relatively pain-free, requires only local anesthetic, significantly contributes to pain relief once the pus is aspirated. It's not associated with any significant complications, very safe procedure. But the problem is that it's less reliable in complete drainage of the pus, with this potentially predisposed to a higher risk of recurrence and delayed complications of the peritonsillar abscess. The needle aspiration procedure, if the patient is cooperative, he or she can hold the tongue depressor, preferably combined with a light source. A good suction should be available to prevent any aspiration of pus or bleeding, and a wide bore needle is used to penetrate the plateauglossus muscle into the abscess space. And several attempts in several directions would usually lead to almost complete drainage of the pus. The resolution rate is in the area of about 80%, and if it fails, it can be repeated again because it is safe and easy to do and inexpensive. But it requires patient cooperation, of course, and a Cochrane group study in 2016 pooled results of 10 different studies and showed that the recurrence rate after recurrence of the peritonsillar abscess after needle aspiration alone would be in the area of 23% compared with just 4% for the incision and drainage. The risk ratio is about 4 times for developing a recurrence with the needle aspiration method. A Quinsy knife incision and drainage is usually used when the needle aspiration has failed because it's more painful than needle aspiration, and historically it was associated with some disastrous complications. You could see here an internal carotid artery aneurysm displacing the tonsil and mimicking a peritonsillar abscess. The procedure for a Quinsy knife drainage should start with infiltration by a local anesthetic rather than just spraying the local anesthetic. This gives far superior pain control. The site of the incision should not be higher than the base of the uvula in the upper part of the peritonsillar space, and the incision should not extend beyond the palatoglossus lateral edge. The incision should just be 2 or 3 millimeters deep, and to do this you need a number 11 pointed blade, and it should be guarded. The blade tip should be guarded with a plastic sheath in there to avoid unnecessary penetration deeper into the abscess. Once the incision has been created, a forceps can be used to widen the incision and allows more free aspiration of the pus. This can be helped with irrigation. Some of the pus would need to be collected for a culture and sensitivity. The Cochrane review of the results of recurrence from needle aspiration versus incision and drainage showed clearly the superiority of the incision and drainage method over all the studies. There wasn't a single study which showed a better results for the aspiration, and the net results was clear with a risk factor of about 4 times for recurrences after needle aspiration compared with incision and drainage. Antibiotics would be required in all cases of peritonsillar abscesses. In the small group of patients who have just peritonsillar cellulitis, antibiotics alone may help in controlling the infection. But if there is pus requiring aspiration or incision and drainage, antibiotics would still be required to control the infection. Which antibiotics? A combination of benzyl penicillin and metronidazole for the anaerobes would be the preferred choice. If the patient is allergic to penicillin, then either erythromycin or clarithromycin can be used instead. There is some evidence that benzyl penicillin alone is effective, but considering the high rate of polymicrobial nature of the peritonsillar abscess, particularly in type 2 of the abscess where there are multiple organisms, and the addition of metronidazole is essential. The other line of medical treatment would be steroids in the form of a single dose of intravenous steroid in addition to the antibiotic therapy. And this has been on the rise recently after a randomized controlled trial showed that the steroids would significantly reduce the throat pain, the hospitalization time, the fever, and the trismus, and that there was no increased risk in the use of the steroids. In addition to the antibiotics and the steroids, adequate analgesia would be essential to control the pain for this very painful condition. Intravenous fluids may also be necessary in case there is any risk of patient's dehydration for reduced oral intake. Most patients would be treated as inpatients, particularly in the UK and other parts of the world. In other parts of the world, including USA, most patients would be managed as outpatients with reported high levels of patient satisfaction. The conditions for treating patients of peritonsillar abscess as outpatient is to recognize the risk of any airway compromise or dehydration before taking this decision, and allow a good follow-up plan and protocols, and make sure that the patient has easy access for admission if the condition worsens or is not improving. The other less used line of treatment is abscess tonsillectomy. In children in whom cooperation is required for needle aspiration or incision and drainage, and if these patients require a general anesthetic for these procedures, then abscess tonsillectomy should also be considered. The other indications for abscess tonsillectomy include recurrent or failure to respond to the treatment by aspiration or incision and drainage, or multiple abscesses, like in this case, in which it may be difficult to evacuate the pus from all the loculi. The results are very good, and there are minimal additional morbidity. The operation would almost prevent recurrence completely. There are very few cases of peritonsillar abscesses in patients who had had tonsillectomy in the past. The reported cases were about a dozen cases or so worldwide. There is also no need for the delayed elective tonsillectomy, since the operation of the drainage of the abscess and the tonsillectomy would be combined. The dissection of the tonsil would be fairly easy because the peritonsillar space is now filled up with fluid, with the pus, so the capsule is almost lifted from its bed. If the patient would given a delayed elective tonsillectomy date, this area would have intense fibrosis and would make the dissection of the tonsil in the elective tonsillectomy quite difficult. Main concern with the hot tonsillectomy was the fear of postoperative hemorrhage from the inflamed tissues. The figures does not substantiate such a possibility. In fact, the rate of bleeding is about readmission in theater for arrest of bleeding is less than 1%, which is quite similar to the rate for ordinary tonsillectomy. So there is no statistically significant difference between adult abscess tonsillectomy and elective tonsillectomy. Interestingly, most of the bleeders was coming from the contralateral side, the side that did not have the abscess itself. The tissues were still inflamed on this side and perhaps more vascular, but there was no clear plane of cleavage like on the abscess side, and that's where most of the bleeders were found. The advantage of abscess tonsillectomy is fewer days of morbidity, and the recurrence rate is almost next to zero, and of course you don't have to consider elective tonsillectomy later. On the other hand, presence of trismus and the edema in the oropharynx would add to the intubation risks of the general anesthesia. There are still open questions about who should be offered the elective tonsillectomy operation after developing a peritonsillar abscess. Would it be to all patients after just one single episode, or patients who had at least 2 episodes or more than 2 episodes? The figures after tonsil conserving treatment by aspiration or incision and drainage showed a recurrence rate of about 11% within 5 years, and that may increase to about 22% within up to 35 years later on the ipsilateral side. So the numbers needed to treat would be between 5 and 10 patients for these quite significant rates of recurrence if aspiration or incision drainage alone are used. Probably 2 episodes of peritonsillar abscess would justify having the risks of an elective tonsillectomy. In addition, there would be a subset of patients who have a higher risk of recurrence, the age between 20 and less than 40, who have recurrent tonsillitis. These may be considered for the interval tonsillectomy, even if they don't have 2 episodes. A recurrence rate is very rare above the age of 40, so that shouldn't be an issue. The patients above the age of 40 should not be offered elective tonsillectomy. And finally, to the prognosis and the complications of the peritonsillar abscesses. About 15% would recur, typically the young and those with a history of recurrent tonsillitis. Progression from a peritonsillar abscess into a deep neck space infection like a parapharyngeal or a retropharyngeal abscess would occur in about 1.8% of the cases, and on their turn, this 1.8% of the cases may develop mediastinitis in about 10% of them. This is a fearful complication because the mortality rate is in excess of 30%. If necrotizing fasciitis developed after the peritonsillar abscess, which is a rare complication, treatment would include, beside the broad-spectrum antibiotic, abscess tonsillectomy and wide debridement of the necrotic tissue. In the case of an abscess that is going to spread into the neck, abscess tonsillectomy would be the answer of choice. By this, we come to the end of this presentation on peritonsillar abscess quinsy. Assalamu alaikum.